Okay, so here we will listen to experiences from 3 neighboring countries. First, we would listen to digital health interventions in COVID times from India, then delivering under changing political landscape, a case from Afghanistan, resilience and digitizing sexual and reproductive health response under COVID times from Bangladesh. So without taking much of your time, I would like to take this opportunity to introduce our esteemed moderator for the session, that is Dr. Nusrat Nazuddin. Dr. Nusrat is the Deputy Medical Director at Family Planning Association of Sri Lanka. She joined the organization in 2017 and is responsible for sexual and reproductive health service delivery. She has worked both at the Ministry of Health as well as the private sector in relation to sexual and reproductive health and family planning for more than 7 years. In 2005, she graduated from Manipal College of Medical Sciences with a Bachelor of Medicine and Surgery and received a postgraduate diploma in venereology from the University of Columbia in 2013. Thank you, Dr. Nusrat, for joining us. And I hand over the baton to you now. Dr. Nusrat, please.
Thank you very much, Karima, for that lovely introduction. And greetings to our audience, and welcome to the session of overcoming challenges and breaking barriers. There'll be 2 presentations, a video and a Q&A segment at the end. So if you have any questions, please type in the chat and we will address them in the final segment. So the first presentation is FPA India's digital health intervention during COVID times. So Dr. Shamala Dupte, Director Medical Family Planning Association of India. Dr. Shamala Dupte is a preventive and a social medicine practitioner from India and has been associated with Family Planning Association of India for over 10 years. As a Director Medical with FPI, she provides technical assistance to clinic teams of 40 branches across the country. She has 2 decades of experience in the field of public health with focus on women's and adolescents' health and child malnutrition. She also has the FPI's largest abortion project supported by LAD, and during COVID-19, she with her team led the organization's COVID response, which ensured uninterrupted service delivery to the clients. India, the current situation, reported the first COVID-19 on January 30th, 2020, and a nationwide lockdown was imposed by March 24th, 2020. And FPI India continued to provide SRH services, and it is in place for thousands of women to get their SRH needs met. Telemedicine, the first digital intervention, was launched on March 30th, 2020 with no training or infrastructure support. During the most restricted period of COVID-19 lockdown, abortion, family planning, and antenatal care was served via telemedicine. And DHI, such as mobile-based apps for screening and triage, online staff training, and webinars were eventually introduced. After over a year of experience, FPI India successfully adopted telemedicine as a routine service delivery channel. And it has many other digital ventures in the pipeline to help enhance access to SRHR for the most hard-to-reach population. Saying this, over to you, Dr. Shamala. You can start your presentation.
Yeah, thank you, Dr. Nusrat. Let me just share the screen. Can you all see the screen now?
Yes, Dr. Shamala, we can see your screen.
Okay. Good afternoon from Mumbai. Dr. Nusrat, thank you very much, and thank you IPPF for inviting me to talk about this very overwhelming experience of COVID times. And everybody has suffered, the entire world suffered of this COVID pandemic, and it is still the end is not visible. But how we try to overcome the challenges and provided service delivery, which is our commitment. So in next 15 minutes, I will give you a short, and Dr. Nusrat actually has, summarized what I'm going to speak. Thank you very much for that. Before I begin, one slide about FPA India. FPA India was founded in 1949. It's the National Voluntary Organization, leader organization on SRHR. In the photo, you can see our first Prime Minister and Madam Margaret Sanger and our founding member, Dr. Dhannavanti Ramarao. Very proud to put this photo in every presentation. And on the right side, you can see that FPA India, we have a pan-India presence. India is a very big country, and almost all the four corners, you can see a rhombus here. We are trying to cover all the possible areas that we can. And we have a network of SDPs, service delivery points, 39 static clinics, UFWCs, that is Urban Family Welfare Centers, 19, 56 mobile clinics, 19 satellite clinics, and we also network with private doctors, about 119. These are 2020 figures, so this could be a little odd numbers. And associated clinics 229, and CBPs, the community-based depots or community-based providers, which are a one-person SDP, over about 500 of them. So through them, we try to reach about 35 to 40 million people each year. And the thematic areas we work on are similar to the other fellow MAs, like family planning, MCH, comprehensive abortion care, livelihood and skilling, comprehensive sexuality education, STIs and HIV, and also GBV. And last but not the least, we are very proud to say that we are one of the 8 founding member associations of International Planned Parenthood Federation. After this, let me quickly take you through the timeline of COVID-19. Dr. Nusrat gave us all the important dates that that were important milestones in the COVID journey that we had. In India, first COVID case was detected on 30th of January 2020. And in that 1 month, it was a havoc situation. The cases rose exponentially, and Epidemic Disease Act was invoked by Government of India on 11th of March. And 12th of March, the first death was reported. The Epidemic Disease Act means that the legal angle came into picture. Every case of COVID was notifiable to the government because it was a dangerous public health situation. On 23rd of March, an appeal was made to all the FPI branches by our Secretary General to continue SRH service delivery. That entire week was full of chaos. Our clinics were closed only for 1 day because of the confusion. But on 23rd of March, appeal was sent, and the next day, on 24th of March, the entire country of 1.35 billion people came to a standstill. The national lockdown was announced by government, and mobility of people was completely restricted. And after that, for 1 week, we were having continuous internal deliberations on how we can reach out to our people and how we can provide them with the services. And what we thought of first was to introduce telemedicine. On 30th of March, we started telemedicine services in the clinics. And I'll be talking about this in detail in the later slides. Government had to come into the picture and release an official statement that family planning, safe abortion, MCH, and HIV/AIDS are 4 essential SRH services. And this was very important for the law enforcement officers because they were restricting our health workers, our clinic staff to reach. They were restricting them from reaching to the clinics to be able to provide services. Initially, it was thought that 21 days battle and we will win this battle against COVID, but lockdown was extended, and the situation was such that it kept on extending. On 27th of April, we launched mobile app COVID Nirikshak. I'll be talking about this later in details. And then we realized that this is not going to end soon. So we started using digital interventions. We started using digital platform to continue with our routine services, routine activities like virtual trainings of staff, webinars, and online CSC programs, etc. In 2021 second COVID wave hit the country. This time, the lesson was learned probably that nationwide lockdown has many repercussions. So there was no nationwide lockdown as such, but there were state-wise lockdowns, mini lockdowns, weekend lockdowns, something like that. That did not affect the service delivery as much. But now, recently a statement came from Dr. Soumya Swaminathan that India may be entering endemic COVID stage. And that means that we have to live with the virus. The virus is not going anywhere soon. And we have to continue with all the prevention measures, and we have to keep using the new service delivery routes that we have introduced during the lockdown. And the table below gives a glimpse of the magnitude of the COVID that India faced. And the numbers are huge. 34 crores of cases were there, and the recovery rate was good. Although the total deaths in absolute numbers, if you see, it is like 465,000 plus souls they lost their lives, and among them about 700 plus doctors also. So healthcare workers were also badly affected. Now, the impact of lockdown on SRH service delivery because of the restriction on mobility, and the authorities were clueless about the essentialness nature of the SRH services, which led to more barriers in accessing SRH services, which otherwise were, at least in the bigger cities, they were easily available, which led to the steep decrease in the clinic footfalls, especially FP abortion and antenatal clients. And why these clients are more important than the other clients is that the health issues involved in these cases have natural progression. They do not stop because there is COVID. They do not stop. An antenatal woman, a pregnant woman, will not, her pregnancy will not stop progressing because there is a lockdown, and she will need health care. The challenges during COVID-19 pandemic, it was a new virus, new epidemiology. Every day, new information was being bombarded. A lot of fake news was also there. And we, sitting in headquarters, we had to take in all the information, filter out, and then take it to our branches so that they were able to give that information to the clients. There was a need for constant update on the developments, as I said. Keeping up morale of the staff, especially the frontline workers, was one of the most challenging thing, especially during the second COVID wave, because lots of deaths happened during the second COVID wave. And demand for new services, new mode of service delivery, because the traditional routes of service deliveries were non-functional. That's when the telemedicine was adopted by AFGHA to continue the service delivery. So this is at a glance at what DHI, the digital health interventions that were taken by AFGHA. Telehealth using mobile phones to provide counseling, consultation, follow-up education. Then COVID screening app, COVID Nirikshak. Again, I'll be talking about that later. Service provider networking through virtual meetings, which was very, very important, because what's happening in the other states, what's happening, India is a huge country. So being connected is always very important, and virtually it was continued during the difficult times. Webinars with partners for the CMEs, that is continuing medical education, were also later on adopted, and online youth focused programs were also conducted. So the telemedicine in India current scenario is before COVID, it was very restrictive. I'll be very straightforward about this. But during May 2020, that is during the first lockdown, telemedicine's guidelines were issued by Government of India. Before that, it was illegal. Online prescriptions were illegal. But later, the guidelines gave us some hope, some direction towards, a push towards taking telemedicine, adopting telemedicine. Delivery of healthcare services, what is it? It is using technology to deliver healthcare towards people, not in person, but using technology. and not just for diagnosis, but for prevention and treatment of diseases. And it can also be used for research purposes and education. Now, after the guidelines are issued, a trained allopathic doctor can provide telemedicine services as per the specifications. The government has also released a list of drugs that can be prescribed through telemedicine. The list is expanded to include psychiatry drugs and the NCD, non-communicable diseases drugs. But unfortunately, it does not enlist the medical abortion pills as of yet. So medical abortion is not. And on the right side, you can see the government also proactively took up the digital medium for providing healthcare services through EOPDs, and they also launched a helpline for telemedicine. In FPA India, telemedicine, we had thought about telemedicine even before COVID came into the world. We had conducted this video consultation training in partnership with Tech Mahindra in the remote clinics that we have up in the North Bengal, in Kalchini. But we had a lot of problems and challenges because of the network and the bandwidth demand, which was poor in the remote area. And that's why we could not take it ahead, but we were thinking about it. But COVID literally pushed us to adopt this new service delivery route. We went straight to whatever we had in our hand. We did not wait for a new infrastructure or whatever. Everybody knows mobile usage is very high in India. And it is an effective medium of delivery of healthcare services at a low cost, relatively low cost. I would like to take some names of the companies which are providing it at a very low cost, but I think everybody knows that. Best suited for telecounseling. There is no need of video, so the privacy, especially the video privacy, is very well maintained. So telecounseling is something that we saw that after when we looked at the data of the telemedicine services, telecounseling was very well received by our clients. Service providers willing to share personal numbers was very important. Our doctors, our consultants, they were willing to share their personal numbers when we started thinking about this. And many other services could be provided, like telephonic follow-up, and other services could be provided using this. And even the product-based services could be provided through our network of link workers. So telemedicine did not restrict us from providing product-based services. For example, supply of condoms, supply of oral pills, because every branch has a network of link workers whom we could contact, and then they could go ahead and provide the services. Now, I'll go through the steps of what we did when we introduced telemedicine. And all this happened within a span of 3 to 4 days. First of all, the telemedicine guidelines, FPA guidelines for clear do's and don'ts were in the line with Government of India guidelines that were prepared and circulated with the branches. Service providers' consent was taken so that their number could be popularized in the communities. And a resource bank was prepared in the form of an Excel sheet where India is a multilinguistic country. We have 14 official and the thousands of other languages. So we had to prepare a resource bank with service providers' language ability, as well as their location and the time available. So this resource bank was circulated with all the branches, and along with that, the service, telemedicine service, was popularized in the community by our link workers. This is the telemedicine client record slip. Every client needed to be recorded for the legal purpose as well, because many clients, they approached us for COVID-related information, and they gave us they shared that they had symptoms suggestive of COVID. So all these cases had to be reported to the government wherever they identified themselves, wherever they revealed their identity. Now, this is the Excel sheet, the resource bank that we prepared, and the service providers. You can see. I don't want to give a lot of data about what happened after the telemedicine services, but this is an interesting graph comparing the two lockdown periods, April to June 2020, the first COVID lockdown in India, and April to June 2021, the second one. And the first graph, if you can see, The 3 is, these are all percentages. So 3 is total telemedicine services, where 3% of the total SRH services provided by FPA India. So in the first lockdown, the total telemedicine services were 3%. In the second lockdown, it came down to 1%. But if you see, abortion-related services total were 9% and in the first lockdown, and later it came down. In the second lockdown, it was 6%. Family planning services were 22% in the first lockdown, but 6%. So the product-based services were much reduced in the second lockdown. They were very high in the first lockdown, if you can infer that way. ANC services, again, a physical examination is necessary, so not much of a change there. But if you see the GBV services, they have increased in the second lockdown. And women are adopting this method, this route to convey their GBV-related issues to the service provider. They are preferring this method, and COVID-related services like giving information awareness and referral was again increased in the second lockdown. Other SRH services were the services which were not announced as essential services, like gynecological services or infertility-related services, male SRH services. They are included in this last. Now, COVID Nirikshak means inspector. So a COVID watcher kind of guard. So this was a screening app which was developed in partnership with a private organization. And it was majorly used for thermal screening using algorithm so that there was no mistake. While there was no subjective decision taken by the service provider whether to refer the case or not. And the symptom-based screening was also provided, and contact screening was also done for those who were suspects, positives. And based on the outcome, referral was provided to the Government of India facility because we were under the Epidemic Disease Act. So you can see on the right side, this is the interface of that app. And we had the screening tool, which was fed into the app. And that's how our health workers were using it in the clinics. Faster data entry, electronic medical records, and automatic report generation. It was linked to eCMS. 26,000 plus COVID screenings were done, and all were given risk reduction information, and 736 persons were referred for testing the government facilities. Last couple of slides, virtual staff trainings were conducted. Medical abortion training on medical abortion provision was provided to our clinic staff, and they also conducted meetings with link workers, which was very important during the lockdown because link workers were providing the product-based services in the communities. Then FPI has also introduced webinar series for CMEs. During the first lockdown, the first webinar was conducted in May 2020, 27th May to be precise. And at present, spotlight series on MTP Act, Medical Termination of Pregnancy, that is the Abortion Act, at 50 because it completed 50 years in India now. That abortion is legal. A move on right track with partners to provide innovative platform for abortion-related deliberations is going on. There are 6 planned webinars, 4 are over and 2 are remaining. Looking forward to that. For youth, we have introduced online CSE programs. There is a hybrid model. That means a few sessions are online, a few sessions are in person. And there is going to be a separate presentation on this topic, so I will not go in the details. For this Zoom, Gmeet, Skype, whatever medium was available, branch-wise those media were utilized, and WhatsApp was used for circulating the message. Webinar on National Youth Day on 12th January was conducted. Instagram live chats. These are the new ways youth would like to interact with each other, and that is adopted. International Youth Day was celebrated, and International Day of Girls. Other initiatives are, these are project-based at present, only locally in few branches. So under Noida project, a hotline line toll-free number is circulated for telecounseling and teletriage base mainly, and with our own foundation, a similar venture is going on in the other branches. We are also in collaboration with MTV Nished. They do TV series on various SRH issues, and on their website there is a clinic finder, and FPAI, all the branch locations are enlisted on the website, so the people can approach us through that website as well. Telemedicine we have adopted as a routine service delivery. Many surveys have shown that telemedicine is here to stay. It is not going anywhere. People want to use telemedicine because it saves time and cost, and also they can discuss uncomfortable issues with the providers. Future scope, FPA's own telehealth digital application, which it is very much in the pipeline. M-Chikitsa is the name. Chikitsa means a diagnosis, and leveraging telemedicine to improve access to SRH services is something that is very much coming up. Association with online pharmacists for again supply chain management is one limitation that telemedicine has, and that we would like to go ahead with this kind of associations with the pharmacists so that the loop is complete, the service delivery circle is complete. E-training courses for doctors on family planning can be conducted virtually, and advocacy towards amendment of the act to enable e-pharmacists to be able to sell MA drugs so that the access improves, and inclusion of MA drugs in the drug list for e-prescriptions. This is something that we want to do. Thank you very much. The last quote is telehealth allows patients and providers to grow closer and give much better care, as said by Dr. Suzanne Shah, because telemedicine, it feels that it is not impersonal and it doesn't have face, but what the reports and the survey show that it is the other way around. Thank you very much.
Thank you, Dr. Shamala, for that lovely presentation and sharing FPAI's strategies, innovative methods, which ensured continuous, uninterrupted SRH services during difficult times. Thank you again, Dr. Shamala. Once again, a kind reminder to our audience, if you have any questions for Dr. Shamala, please share them in the chat so that we can address them in the final segment. So we have come to the end of the first presentation. We'll move on to the second presentation. And the title of the presentation is Delivering Under Challenging Political Landscape, a case from Afghanistan by Fazal Mahmood Ali, who works with IPPF member associate, Afghan Family Guidance Association as a monitoring and evaluation manager with more than 5 years of experience. He previously worked with the Afghanistan Anti-Corruption Commission and an independent joint anti-corruption monitoring and evaluation committee. He holds a master's degree in interdisciplinary field of public economics, laws and politics from Leuphana University of Lüneburg in Germany, and a bachelor's degree in economics from Nangarhar University in Afghanistan. A little bit about Afghanistan's current situation. In addition to the COVID-19 pandemic and ongoing violent conflicts, Afghanistan's recent political turmoil has affected the lives of millions of Afghans, heightening the need for and urgency for AFGHA services. Fazal will be discussing the challenges and how these changes in the political and security landscape pose to the MA, as well as how AFGHA is addressing these challenges in his presentation. Over to you, Fazal. You may start your presentation now.
Thank you very much, Dr. Nusrat, for your kind introduction. Assalamu alaikum wa rahmatullahi wa barakatuhu. Namaste, Khosh Aamdeed. Hello, everyone, and good afternoon. For those who do not know me, my name is Fazal Mahmood Ali from Afghanistan. I work as Imini manager here in the Afghan Family Guidance Association, or AFGHA, since September this year. Today, as you can see on your screen, I will be presenting on the topic of delivering under changing political landscape. That will be a case from Afghanistan. For the agenda of this presentation, I will first talk about AFGHA's journey since its inception in 1968, followed by a brief history of the turbulent political history of Afghanistan and how it impacted our work specifically and the health sector in general. Next will be the strategies and principles AFGHA used to handle itself during these tough times. This will be followed by the way forward for AFGHA, where I will present about opportunities and challenges that we have and will face in the future. And at the end, we will have a short conclusion. To start with, AFGHA had a proud journey since its inception in 1968. That year, AFGHA was inaugurated by the daughter of the first president of Afghanistan. Her name was Princess Khatol. As you can see in the picture, she is inaugurating AFGHA. AFGHA is proud to say, to call itself one of the oldest non-governmental organizations in Afghanistan. AFGHA was established with the aim of providing families, especially women and girls, with sexual and reproductive health counseling and contraceptives. After its first decade of providing services, the 80s and 90s was a tough time for AFGHA. In 1979, the Soviet Union invaded Afghanistan and were here until 1989. In the 90s, the country was engulfed in a civil war, and AFGHA had to cease and close its activities, unfortunately. The last 20 years was a resuscitation period for AFGHA. We not only resumed our activities in 2002, but also expanded our services to vulnerable people living in remote geographical locations across Afghanistan. Over the last 20 years, AFGHA also initiated and implemented activities that empowered women and youth to learn more about and take decisions regarding sexual and reproductive health. AFGHA services also made and is still making a huge difference in people's life at these struggling times and challenging political insecurity situations. Speaking of struggling times, I would like to take you a little bit back in the history of Afghanistan and show you the turbulent political and security landscape Afghanistan had and is still having, and the implications it imposed on organizations such as AFGHA. If you don't know a lot about Afghanistan, we are unfortunately a country traveling on a very bumpy road of politics and security. From 1978 till 2021, just this year, we had 5 regime changes. I'm not talking about government changes, it's the whole regime changes. In the middle, we had a lot of government changes, but 5 major regime changes, starting from the communist regime in the 1980s, Mujahideen in the early 90s, the Taliban for the first time in the 90s, and then in early 2000, the Islamic Republic, which was established in 2001 after the 9/11 incident, and now from August 15 this year, Taliban again. This last regime change that has just recently occurred complicated an already challenging situation hit by the COVID-19 pandemic. Every regime change and its accompanied violent conflicts affected millions of Afghans, depriving them from reaching basic health services. These conflicts resulted in the destructions of health facilities, left the health sector underfunded and under capacity. According to an estimation during the last 20 years, what the government spent on war in a single day, it could build a state-of-the-art hospital. So that estimation sums up the situation and the state of healthcare in Afghanistan and the attention that the government gave to other sectors rather than the security. The ongoing war not only took government's attention away from improving the health care system, but also made healthcare facilities and workers direct targets of violent acts. According to the World Health Organization, during the last 20 years, on average, each year, 70 health facilities came under attack. or damaged either deliberately or as a collateral damage. Also, on average, each year, around 90 health facilities were forced to close because of violent conflicts. The problems were further complicated when it comes to family planning in Afghanistan, especially in rural areas. With the rise in religious fundamentalism during the conflicts, people's perception did not get any better regarding family planning. The number of child marriages kept constant and rose significantly in rural areas, due to which fertility, birth, and maternal death rates have been on the rise as well. For example, a recent UN report found that nearly 18% deaths among women of childbearing age are due to pregnancy-related issues and complications. Among all this, misconstrued religious teachings led to a perception among people that family planning is not in line with Islam. Continuous violent conflicts also left many people uneducated. According to UNESCO, the literacy rate for the country stands at 43%. For men, the rate is 55%, and for women and girls, it is staggeringly low at 29.8%. Lower literacy rates, especially among women, and lack of awareness left these people unempowered, unable to make better decisions for themselves. Another consequence of the turbulent political and security landscape is that the various governments were not able to pass and implement supportive legislations and strengthen institutions in the health sector, especially in the realm of family planning. Although governmental health institutions such as the Ministry of Public Health and health NGOs were improved in the last 20 years, but with the recent change in the regime, the achievements of the last 20 years are endangered. And a good example of this could be that most of the health facilities and hospitals are currently suffering from underfunding and lack of supplies. So to give you a little bit perspective from using some pictures, here is a picture of the 1979 invasion of the Soviet Union of Afghanistan, which was followed by the Mujahideen resistance well in the 90s, and then in the early, well in the 80s, and then in the 1990s, they were fighting with each other to take power. And then in 1996, for the first time, Taliban took the power until 2001, when the 9/11 incident happened and a new era started where the Islamic Republic was established and continued until this year. During these conflict situations, Afghanistan healthcare system has been affected badly due to these upheavals. Numerous health facilities were destroyed and left in bad situation because of the violent conflicts, and millions of Afghans, including women and children, are deprived of essential health services, including sexual and reproductive health services and family planning. So now many of you might ask, how does AFGHA manage its operation in such a challenging environment? Well, first of all, we are proud to say that we have a capable team with a mindset of not giving up no matter what. If it was one thing that kept AFGHA running through these difficult times, it is definitely the dedication of our staff that made it possible to provide our services to vulnerable people during these crisis situations. A big example of this could be our services during the COVID-19 pandemic or during the current political and security change in Afghanistan. Another key to our success is a relationship with stakeholders, including donor, partner institutions, government, and most importantly, clients. Our relationship is based on trust, mutual understanding, and quality of our services. In political crisis situations, it could be very, very easy to fall a prey to political agendas of certain groups. In this regard, AFGHA is proud to say that it kept its impartiality and independence and focused on providing quality services and helping vulnerable people. One thing that AFGHA found significantly helpful during political turmoil is adapting to the situation and being flexible while not compromising on the quality of its services. For instance, after the 15 August regime change, this year we trained our staff on how to present themselves while having interactions with the new government authorities of the Taliban, separated male and female staff workplaces, and advised our field staff to dress in acceptable ways that might otherwise raise sensitivities. Our proactive approach made it possible for us not only to continue providing quality services, but also expand our operations. Currently, AFGHA provides and continues to provide its services through around 250 community outreach midwives across Afghanistan. They serve mostly in remote areas and provide their services to people who do not have access to proper clinics and hospitals. We also provide our services through 9 static and 2 mobile clinics that are also located in populated areas. And the mobile clinics, they have different locations where they provide, the staff provide its services in remote locations, mainly in Kabul. So now the question is, how is the way forward? What are the perspectives for AFGHA? What are the challenges and what are the opportunities? Well, there are several challenges. For example, there are a lot of uncertainties about the current government's stances on the NGO's operations. So far, they have at least spoken that NGOs can operate and they will provide supportive environment to them. But since it's only over 100 days of their power, anything can change, and we do not know whether they will change their stance or not. Many NGOs ceased and closed their operations either because of the fear of punishment or because of lack of funding in Afghanistan. Another challenge is that the Afghan health sector is currently struggling to hold itself together and cannot fulfill the needs of the population. Hundreds of health facilities closed their doors simply because they could not even pay the salaries of the doctors and nurses. Currently, most of the public health sector employees did not receive their salaries for the last 3 to 4 months. They're out of supplies and equipments. Another possible challenge that we might face, we do not have it until now, but we might face it in the future, and that could be the increased sensitivities towards family planning services. Until now, we have not seen any significant challenge in this regard, but with the Taliban in power, a group that is predominantly religious, there is a good chance that anti-family planning sentiments might get stronger in Afghanistan. One significant challenge that already impacts our operation is the fact that we are now living in isolated Afghanistan, unfortunately. Sanctions from the outside world and the new regime inevitably shadows the operations of NGOs and the lives of ordinary Afghans. Currently, we have difficulties with fund transfers from donors, cashing out from our bank accounts and paying for our supplies. Even worse, there is a good chance that the banking system in Afghanistan might collapse altogether if the current restrictions continues. For example, just yesterday, Reuters reported, citing a UNDP report, that the Afghan banking system might collapse altogether in a few months at time if the situation continues and if the restrictions are in place. And if this happens, that will be colossal loss, not only for the people, but also for NGOs such as AFGHA, and even for those who are outside and want to help Afghans here in Afghanistan. So these were the major challenges that we face or might face in the future. Now, what are the opportunities here for us, for AFGHA? First of all, we have the experience, most important. Operating for more than 50 years in Afghanistan gives us the valuable experience of how to handle a difficult situation. While many other national and international NGOs seized and closed their activities, AFGHA stood strong and it stood tall to deliver its life-saving and important services to vulnerable people, especially women and girls in remote areas of Afghanistan. We think this unfortunate situation as an opportunity to reach out to those who need our support. At the current juncture of political and security turmoil, we provide our services throughout Afghanistan. As I said before, we have around 250 community midwives, 9 static and 2 mobile clinics. We also have trained in partnership with YPeer, more than 350 young girls and boys on comprehensive sexual education, or CSE. These services are a strong testament of our commitment to delivering no matter what, which is the theme of this forum. AFGHA survival and commitment at these difficult times enhanced its image and credibility among donors and stakeholders. In the last three months, for example, AFGHA raised funds for 3 new projects worth around $1 million. And it still continues to attract more funds in the future. So AFGHA's success became possible with its own commitment and a supportive regional office in Saro and a supportive international office in IPPF, which we are thankful for, and we thank their contribution and support at these difficult and turmoil times. We think this international support in the health sector as a great opportunity to provide our services to vulnerable people in Afghanistan. As a conclusion, we can say that AFGHA might not be operating in one of the best environments in the world from a security and political perspectives. But it cannot stop us from serving vulnerable people, especially women and girls. The difficult times we are going through make us stronger. We built on our experiences to keep going. And with that, anything is possible, but we are prepared. And yes, we can do it. Thank you.
Thank you, Fazal. Thank you for sharing the insight into your immense challenges in providing SRS services to the community during this very restricted situation in your country due to the political unrest and the COVID-19 pandemic. So thank you again, Fazal, for that lovely presentation. So we have come to the end of the second presentation. Just a gentle reminder again to the audience, if they have any questions for Fazal, please type them in the chat so we can address them in the end of the session. Moving on to the third segment of the session, very interesting session though. It's going to be an interesting and informative video. The title of the video is Securing Access to SRHR During COVID-19 by an esteemed Dr. Sanjeev Ahmed, Executive Director, Family Planning Association of Bangladesh. Dr. Sanjeev Ahmed has more than 2 decades of experience in public health and development sector in Bangladesh. He has worked with both donor and implementing agencies. His core area of expertise are quality assurance, capacity development, and training and project management. Dr. Ahmed has expertise in developing implementing and evaluating multi-million-dollar projects in health system strengthening and health service delivery, focusing maternal and neonatal health, adolescent health, family planning, SRHR, and nutrition. He has led and motivated diverse teams of interdisciplinary professionals being with different national and international organizations. He holds an MBBS and a Master's of Public Health in Hospital Management. Prior to joining FPAB, Dr. Ahmed worked with USAID as a project management specialist. And over to you, Dr. Sanjeev Ahmed. You can start your sharing the video.
Thank you very much, Dr. Nusrat. And very good afternoon to you all who are participating in this session. And I am very much honored to be a panelist here in this session. Before showing this video, I want to give a brief introduction of this video, under which condition this video has been made. You all know that in South Asia region, Bangladesh is one of the worst hit countries of COVID-19 outbreak. And this situation further worsened because of many factors. And at the same time, all service delivery, health service delivery facilities, public sector and NGO sector and private sector, all facilities were busy with the COVID-19 response. And the sexual reproductive health services and gender-based violence service system was hugely neglected. As a result, what happened? There was dramatic rise of unintended pregnancies, gender-based violence, child marriages across the country. Under this backdrop, there were also a countrywide lockdown since March 2020, because the first case identified in Bangladesh was in 8th March, and after that, government went through a countrywide lockdown. And afterwards, when situation got a bit better, there were area-specific lockdowns, that is local level lockdowns. Though there was the movement restriction for the clients, for our service providers. There were scarcity of vehicles. Clients, even clients were in fear attending our service delivery points in person. And in many instances, they did not allow our field level workers to visit their homes even. So in that situation, FPAB felt the need of providing digital health intervention and came up with full range of services through hotline numbers and through telemedicine, limited scale telemedicine services. And also in some cases, the comprehensive sexuality education, schools were closed, so comprehensive sexuality education and other youth-focused intervention school-based intervention are impossible. So there were provision of online CAC session and other intervention. So doing that, we felt the huge need of the demand generation among our client base, and demand generation and service promotion was the key to success. And for that reason, we have developed many videos, mini clips, video clips, audio drama, and use different social media, online platform, community radios to promote our services. In line of that, we have developed these materials focusing different target groups, different materials, and most of the materials were in Bangla. But we have developed this video, which I'm going to show you today. This video was developed focusing the target group among our NGOs, CSO forums, our donors, our other development partners, and our partners around the globe. So this is the video. Here in this video, you will see the overall glimpse of DHI that has been implemented by AFGHA during the COVID-19 response. Thank you. So now we will see the video. Garima, sound is not coming.
Shilpa, there's no sound.
The government has announced the closure of all educational institutions across the country till 31st of
May we play the video from beginning? Yes.
The spread of coronavirus is accelerating.
现在还是有出现传人的这个现象。
We're seeing false and misleading information. It's kind of strange.
医疗人员和防疫物资的紧张仍然是武汉 and unprecedented quarantine. Wuhan and central China and nearby cities in lockdown.
Bangladesh is also under the attack of deadly coronavirus. We have identified 3 patients. I'm giving you the basic information about them. 2 are men and a woman.
Dhaka is under lockdown.
The government has announced the closure of all educational institutions across the country till 31st of March to avoid health risks posed by coronavirus.
When the deadly COVID-19 pandemic caused severe crisis everywhere and the overall health of public was in danger, the field members along with the employees from all departments of Family Planning Association of Bangladesh, FPAB, not locking themselves at home, came forward to shoulder the responsibility to serve the people. Attention please, there is no substitute for awareness. Wear a mask and clean your hands properly. Campaign by Family Planning Association of Bangladesh, FPAB.
During COVID-19, FPAB provided us with hand sanitizer, mask, and many other protective items which aided us immensely that we couldn't afford with money. They made us highly aware. FPAB during COVID-19 helped us a lot. Their field workers came to us and gave us birth control pills, condoms, and other such items. That's why we didn't need to go outside to buy those items at that time. We received everything staying at home. FPAB helped us greatly.
Due to COVID-19 pandemic, people had to accept confinement and various forms of physical and mental difficulties were seen among people. Moreover, sexual and reproductive health services for adolescents and pregnant women were faced with grave danger. Against these backdrops, this project is funded by Global Affairs Canada and is being carried out by FPAB, where the health protection of pregnant women has utmost importance.
Hello, Assalamu alaikum. How can I help you? Yes, how can I help you?
আমার বোনের 5 মাসের প্রেগন্যান্সি চলতেছে আর এই সময়
Violence against women also got escalated in Bangladesh like other parts of the world during this COVID-19 pandemic. That's why counselors of FPAB, through an online service, stood beside the victims of violence.
During this COVID-19 pandemic, like other areas of the world, violence towards women is soaring up in Bangladesh. We get many calls every day. We are offering the victims telephone counseling. We try our best to provide them with effective solutions. We have helped many women financially through the GAC project, and for the legal assistance, we have referred them to the proper authorities.
Under the GSC project, taking support from NGO and the government, we have executed our program in a coordinated way, and in doing so, the health protective equipment which we received during COVID-19 pandemic played a pivotal role. During COVID-19, through the GSC project, Family Planning Association of Bangladesh was involved with our divisional programs, along with all other activities, to carry out our birth control program, online counseling service, delivery, and the diverse sides of our family planning methods, especially the clinical activities. Family Planning Association of Bangladesh is working efficiently and relentlessly.
COVID-19 pandemic has swept the whole world. During this time, Family Planning Association of Bangladesh, being financed by our donor organization, is running some projects in all districts. One of the significant projects among them is securing access to SRH information and service during COVID-19, and it is funded by Global Affairs Canada. We have been carrying out the project since August 2020 in all districts to ensure reproductive health service. Through the GAC project, we have implemented several initiatives. One of the initiatives was hotline service. Therefore, to maintain adolescent services, we have run various online sessions with the GAC project's financial assistance. Dear participants, I welcome all of you to today's new session.
During the COVID-19 pandemic, with a view to providing services to people who are stuck at home, this digital health service project, funded by Global Affairs Canada, is being implemented in every branch of FPAB. In this project, adolescent health protection is being given the most importance. Adolescents are being trained and instructed about the comprehensive sexual education, youth-friendly service, and youth protection policy through online sessions. In every lively session, numerous sexual and reproductive health protection topics are discussed with enormous importance.
Basically, through webinars, we are presenting the issues regarding SRHR to our dear learners so that they can be benefited from the sessions like they used to be before the pandemic.
The way I'm being helped by the FPAB online sessions, I want my friends and people around me to be so. During this COVID-19 pandemic, there are 2 mobile numbers in operation in our 21 clinics for counseling and consulting, respectively. Our clients are calling us regularly. The number of calls is constantly increasing. We have received 26,077 calls in the last 4 months. And based on those calls, we are making follow-up calls. Our clients are pleased as they get these services staying at home. Based on this, we have started a small-scale telemedicine service. There is an opportunity for video consultation here. As we are getting almost all facilities staying at home at present, we can hope that our clients will be immensely benefited from this video consultation. Are you fine, madam? Yes, I'm fine. You were talking about your problems the other day and wanted to talk to our doctor. That's why I've come to you today. Let's meet the doctor through a video call. Inform her about your problems and see what she suggests to you. Assalamu alaikum. Walaikum assalam. What's your name? My name is Iti. How old are you? 28. Tell me about the problems you are experiencing.
Family Planning Association of Bangladesh by FPAB.
Family Planning Association of Bangladesh, FPAB, is a member association of International Planned Parenthood Federation, IPPF. During the COVID-19 pandemic situation, our service delivery point clinics, our field force have worked relentlessly. There were several restrictions at that time. For instance, lockdown was imposed in certain areas. There was an insufficient number of transports in some areas. As a result, both our clients and we experienced severe difficulties in reaching out to each other. To improve this situation, we have had the project named Securing Access to SRH Information and Service during COVID-19. Funded by Global Affairs Canada, it was a short-term project. This project gave us a massive mileage, figuring out how our clients can receive their expected services from their residents. And we initiated the work under this project. Besides, we launched a hotline service in all our 21 clinics. We ensured telecounseling services for our clients through this hotline, especially SRH service. And we are providing the gender-based violence victims with suggestions and required services through our hotline service. With an aim to offer excellent health services, there is a number of state-of-the-art equipment, including X-ray machines, in every branch of FPAB. There are medical laboratories equipped with the leading-edge technology and expert medical technologists for the accurate diagnosis of patients' diseases. All clinics of FPAB also offer medical test facilities at a low cost. Family Planning Association of Bangladesh, FPAB, has extended their helping hands towards all people even during various disasters and adversities. They are marching forward with a vision to taking health services to everyone's doorstep in Bangladesh.
Thank you all.
Thank you, Dr. Shaib Ahmed. Thank you for sharing that informative video. There are many key points to consider and innovative SRH measures which we could adapt in our MAs. Thank you so much once again. So we have come to the final segment. We are a segment to address question and answers from audience. So I might pose a question to one of our presenters. If time permits, we might address all the questions, but we will try our level best. So first question is to Dr. Shamala Durke from FPAI. I'll read out the question, Dr. Shamala. Looking at the severity of second wave of COVID-19 impact in India, what you did differently to keep the momentum of SRH on? Dr. Shamala, over to you. Do you want me to read again? Or?
No. I understood the question. Thank you very much. The second COVID wave, the challenges were a little different than the first COVID. The first COVID wave and the first COVID lockdown was full of chaos and confusion about everything, about the transport, about the knowledge of that the authorities had. The traffic police, for example, was not allowing the service provider to reach the clinic. So to be able to provide the services was a challenge. But it took about 1 or 2 months for our clinic officials, the branch managers and the local management teams to approach the local government and seek IDs for the clinic staff. And the district collector or for that matter, where the corporations are functional, there they sought IDs from the authorities so that the movement was easier. And during the second COVID wave, what happened, the entire health machinery, government as well as the private tertiary level advanced care machinery was engaged in providing COVID related care. The SRH care was not available anywhere except for very few NGOs like FPA India. So for the SRH needs, people had to come and approach us. So the second COVID wave, it was a little bit easier in terms of provision of service delivery. It was not that bad. We were already prepared, we had rehearsed, so it was. time. Does that answer the question?
Definitely, Dr. Shamala. Thank you so much for that answer. So I'll direct the second question to, this is to Mr. Fazal. How did AFGHA make sure that women staff were safe, particularly single women?
Thank you very much, Dr. Nusrat, for posing the question. First of all, I would like to say that actually, to be honest, the security situation or the threats are not that serious to health workers as it is or as they are to other people in other sectors. Although there are serious threats to health workers as well, but they might be a little at a low level than to other people. But from AFGHA's side, we took precautionary measures to make sure that all of our staff, especially female young girls and women who works with us, they are safe, and we took care of those measures for their well-being. For example, we made and established connections with the provincial health directorates in the provinces, and they are kind of authorized from the Taliban regime to be in contact with us. We have acquired their authorization cards for our female staff. When they go to the field, they carry it with them. Another measure that we took was to get ourselves adopted to the local custom and the local situation. For example, how to dress when we go to the field. And we also provided the opportunity to our female staff to take with them a close family member, a mahram, for example, father, brother, husband, anyone who can be a mahram for them, and we pay for their fare, and we book hotels for them and accommodation and everything. We also recently employed a security officer, especially for this task, to make sure that the fields, the areas that our staff visit, they are secure, and to give them timely information on the security situation for their visits. Another measure that we took after the 15 August change was to separate the female and male office space. It is a sensitive issue here in Afghanistan. The Taliban think that at least they say that women can work, but they have to be separated from male. So as a precautionary measure, we separated the offices for our female and male staff. But of course, we continue to work together, and our services are not impacted from that side. We also created instant messaging platforms, for example, WhatsApp groups, and other social media groups. So the staff who are visiting the field can easily contact here the main office in case they have a problem or a threat at the field, and we can easily take measure and steps to eliminate that threat. But once again, I have to say that anything is possible. We cannot guarantee 100% that our staff will be safe. But from our side, we try our 100%. We try our best to keep our staff safe and to provide them a secure environment when they provide their services.
Thank you so much, Faza. That was a very descriptive, you gave a whole picture of what you do there, and very impressive. Moving on to the third question, and we have a question for Dr. Sajib from the audience. I will read out the question, Sajib. This is, how did low ICT and low level of awareness impact your digital intervention?
Thank you, Dr. Nusrat. Actually, this has impacted our programming a lot because, the digital health intervention is a highly specialized service and highly equipment-based service. So, and at the same time, COVID-19 response was very much new to us and new to clients, new to us. So we faced lots of challenges with limited resources. So I was talking about, and in the video you see the limited scale telemedicine. That was only actually only video consultation, but full range of telemedicine. For full range of telemedicine, we might have needed the end terminals to examine the patient, to generate reports, to give the online prescriptions. So those were not possible for this low ICT environment. If I told about the, tell about the awareness, I told that COVID-19 was new to us, so we have the limited awareness. The limited awareness was also with the clients. So they were very much unaware where to go for the service, where to be referred, or where to actually, what are the places which are easily accessible. So those informations are not with them. So these were the primary challenges. And regarding hotline, we wanted to integrate our hotline with the public sector hotline number, that is national hotline number. But at that time, the government hotline number was so busy that getting access of that hotline was very much challenging. So in this situation, certainly we had some mitigation issues, but also another challenge was the funding. The funding was very much limited to supply of PPEs and other equipments. The mobile connectivity was not uninterrupted countrywide, and also the call cost of our hotline services, which were implied to the patient end, client end, that was also challenging for us to address during this period. Thank you.
Thank you, Dr. Ahmad. Thank you for sharing your experiences and challenges. And we have come to the end of the session. Unfortunately, we can't address all the questions because of the time constraint. So I would like to thank the audience for supporting us with the questions. And I would like to thank the presenters, lovely presentations, and there's a lot of sharing knowledge and information, which we have so much take-home messages for us to adopt in our countries. Thank you again. Thank you for the team behind Shilpa and Garima. So I shall end the session now, and a great day ahead for everyone. Thank you.
Thank you very much. Thank
Dr.
you.
Nusrat. Thank you, Garima. Thank you, everyone.
Thank you, everyone, for joining us. Good day.
Bye-bye. Bye-bye.
Thank you very much. Bye-bye.